Once again, we want to welcome you all in your different capacities, identities, and dignitaries. We are glad to host you today for this discussion, very important and timely discussion. We are looking at reproductive justice, not just here in Uganda, but across the continent and globally, because we understand that there is a trickle-down effect on issues that affect us at the global level. They also affect us at the regional and trickle down to the national level. So today we have converged here today to have a conversation as different stakeholders, as different key players. And I want to appreciate our conveners today, Sehad Sisimwa IPAS, Mary Stopes, and the Global Fund for Women, who have continued to bring us together for these critical discussions to ensure that matters to do with reproductive justice for women and girls are largely appreciated. Our theme today is around standing in solidarity for reproductive justice, and we all know that we are still grappling as a country, as a continent, on a couple of reproductive justice issues, stemming from how we are performing in terms of our maternal mortality. Like when we look at the global level, we are still having a huge number of 223 mothers being lost at the global level due to very preventable maternal-related health issues. And when we scale down to sub-Saharan Africa, the challenge is even still wide, where we are standing at 545 mothers being lost per 100,000 live births in terms of the statistics. But when you come to Uganda, we want to also acknowledge the efforts that different stakeholders have put in to ensure that since 2016, while we are still in 300s, today we are standing at 189 mothers being lost. The importance of this discussion or this dialogue today is how do we come together into a movement, into stakeholders to discuss these issues, to even reduce this number even much further, because there is no one who would wish to see a mother lost or a girl lost due to preventable related issues. So the discussion today is going to be centered around reproductive justice, and we are very happy to have very many dignitaries here, our dear honorable members of parliament who will come into this discussion, and we appreciate your efforts that you've continued to put in to ensure that we support our women, the girls, but also the men, where we are preaching the role of men and boys in terms of reducing our reproductive justice issues. So today we are here to discuss the agenda around reproductive justice. We are happy that we have the Ministry of Health, who are the custodians of these issues, and also other different entities from the various ministries, departments, and agencies, but also the people who are always behind the voiceless, the civil society fraternity, the media, and the community members who are here today. So we'll straight away go into our agenda for today, our discussion for today. We'll also recognize the members or the people who are live watching us from where you are through NTV and other various social media platforms. We hope that you'll continue with us on this discussion today. Before you, I'm Humza Abdukarim. I head partnerships and communications at Afya na Haki, and I'll be moderating this event today. And we look forward to hearing more insights from the various stakeholders that we have on this event. So we will officially welcome you to this discussion today, and we'll have Nachibu Kanul Musisi, the Deputy Executive Director from the Center for Health, Human Rights and Development, who will be opening up for us as we get into the discussion. Nur, you're welcome.
Thank you so much, Karim, and good morning, everyone. Allow me to once again take the opportunity to welcome you to this dialogue, where we are having great conversations about us, the women, but also the men, the girls and the boys. So to the honorable members of parliament in the House, representatives from Ministry of Health, the development partners in the room, health service providers, civil society, and colleagues from the media fraternity, we really want to welcome you today where we are converging to have a deep conversation around reproductive justice. When we speak about reproductive justice, we make reference to the various obligations we have committed as a country on this right, which requires us to think about how people control their sexuality, issues of gender, work, and reproduction. And we know that this right can only be achieved when women and girls have the audacity to make reproductive choices, including when to have children, especially now that we are having conversations around teenage pregnancies, or not to have children, and how to nurture these children once got. We know that several engagements in the country are happening, and we want to commend the government and the relevant ministries for these engagements. So many years ago, the country was struggling with the high rates of maternal mortality stemming from issues of choice. As we speak today, I'm sure the new statistics that we have as a country, the Uganda Demographic and Health Survey indicates that we are at 189 out of 100,000 live births. Of course, it's not the best, because I'm sure our commitment is to have 70 out of 100,000 live births, but we really want to commend the steps we have taken to reach this particular number as a country. Of late, the efforts by the ministry, I think we see the local maternal neonatal surveillance engagements that happen every day, and lately the national teenage pregnancy surveillance and response mechanisms that are in the country that we cannot just fail to recognize, because these are all efforts that are stemming from issues of women and girls making choice. If it wasn't about choice, we wouldn't be having these conversations and questions of whether the girls choose to become pregnant or not. Sometimes we know, when you look at the annual police crime report, that the rates of abuse, defilement are extremely high, and perhaps could be the reason why we speak about the maternal deaths as well as the teenage pregnancies in the country. So while we recognize these efforts, we really feel like we can do much more as a country. We appreciate the statistics that we have, but we cannot say that we are there. Of late, we have been reading about the cases of maternal mortality due to unsafe abortions, maternal mortality out of hypertension, maternal mortality out of sepsis, and we feel that perhaps it's time for us to ably wake up and speak about these things and see that women are protected. I'll just give an example. Between 2019 and 2023, the Center for Health, Human Rights and Development conducted a retrospective study that was looking at 3 districts of Kamuli, Mayuge, and Wakiso. And why we started from 2019 is because that's the period the country was struggling with COVID-19. And we found that there were cases of teenage pregnancies and abortions that were actually happening. The study was done in phases of 6 months. And it was focused on 6 health facilities, public health facilities, for a period of 24 months in phases of 6 months. We found in this study that within the period, 13,162 deliveries were conducted in the period. And out of these deliveries, 3,661 were out of adolescent girls and young women. And this is almost 27.8% of the deliveries conducted. Remember, I started from an issue of choice. And the questions are whether these adolescent girls and young women chose to actually have these deliveries, or they were just cases of abuse. And these adolescent girls and young women were between the ages of 10 to 20 years. We also found that out of those deliveries, 683 women were seeking post-abortion care services. So we found that 683 women within the facilities were seeking post-abortion care services from 4 health facilities. And this is around 46% of the women 46% of these women were actually adolescents seeking post-abortion care services. So the key questions that we may have to be posing to ourselves are, why would such cases be registered in a country in public health facilities? I'll just give an example. Just last week, we're having a team from Teso and Karamoja regions. We brought them together with the members of parliament and the ministry to just have conversations on what's happening. Of course, based on the research we're doing and projects we're implementing in Teso and Karamoja regions. And one of the things we found were issues around menstrual hygiene management, specifically access to pads, which is a nightmare within the districts. And what do girls do? Once in their periods, they told us they get a skin of a young goat, sit on that skin in a particular place in a house until they're done with periods. So the blood collects on that skin, and then they have a particular place in a kraal where they then pour it, and then you come back and sit on that place. So because of that, what girls opt to do is to actually get away from the community. They're withdrawn from the communities. So once they, in fact, when they don't see you in a community, it basically means that you're having your periods as a girl. So what have men started doing? They have started getting these girls to have free sex for pads. The girls drop out of school, there's absenteeism first, then drop out. Then once they realize, the men will just come up and say, since you cannot afford, we are happy to buy you the pads. And then resultant teenage pregnancies, maternal mortalities, and unsafe abortion. So questions of choice come in handy. Remember, it's not a choice that the girl wants to actually sleep around with a man for a pad. So it's not a choice that they're actually getting pregnant. So I think that these are conversations that we need to deeply speak about. Beyond saying maternal mortality, what is the root cause? And I feel like the root cause comes in with reproductive justice. Issues of choice. Do they make the choice to actually become pregnant? So I really want us to implore ourselves to have open conversations around these issues and have clear strategies on how we handle this. We appreciate the conversations that are already happening, but I think we need to get to the deep cause, the root cause of some of these conversations. So with all these coming through in the country, I really feel like we still have a lot to do to ensure that the rights of the girls and women, but also the men, because when they die, then the men are also affected. When alive, the men also enjoy, are respected, protected, and fulfilled. I thank you.
Thank you very much, Noor, from SEHAD, the Deputy Executive Director at SEHAD. She shares very touching and very critical issues that are affecting our women and girls. And that brings us together to our theme for today, where we are standing in solidarity for reproductive justice. And she breaks down a couple of issues that need our attention and discussion for today. So we'll be diving deep into the discussion around those insights Noor has shared. I will have a keynote address a few minutes later by Dr. Fenel Musana, who is a very experienced person in this field of work. So before we get into the keynote address, we're going to first watch a video which shares some of the experiences, and that will also usher us into the discussion. So we continue live on NTV. Could we enhance on the sound, the tech team?
My name is Star. I've been a midwife for 20 years. You might not like what I'm about to say, but it's my job to talk about it. As a health worker, I've been exposed to too many preventable diseases, and for too long, I've kept silent about Uganda's practice of unsafe abortion. Criminalizing abortion doesn't make it less safe. It makes it more dangerous. An estimated 800 abortions are carried out in Uganda every day. These statistics are far higher than the regional average. In Uganda, over 1,500 women die every year from unsafe abortions. Uganda is facing about double the burden of death from unsafe abortions compared to the rest of the continent. And for every woman who dies unnecessarily, many more are severely and sometimes permanently sickened or disabled. So when it
Video will be a bit more clear in terms of sound so that people can actually get what is being projected. But thank you very much. So we want to get deep into the discussion for today, and we have very experienced people in this discussion for today. After the keynote address, we'll be ushering in a couple of panelists from the different fraternities, and we'll be having their insights as well, and perhaps later hear from the audience on what thoughts you have on reproductive justice. Allow me to welcome our keynote speaker for today, the President of the Association of Obstetricians and Gynecologists in Uganda, Dr. Othniel Musana, to lead us into our keynote address for today that will dive us deep into the discussion. You're most welcome, Doctor.
Thank you very much. I'm not the president, I'm the immediate past president. though I still sit on the committee at the AOGU. So the AOGU is the association we deal with gynecologists in the country, and we drive an agenda to improve reproductive health. So I was given this very difficult topic, given I'm from a biomedical background, but also given that I'm highly conservative. So if I was in the US, I would be voting, you know the man. However, regardless of my beliefs, the realities are different. So it doesn't matter whether you hide or what, the problems are there. So I'll give that background and also speak about what I will say today. Some of the issues have been spoken about, but I want to put some emphasis on key issues and give you a different outlook on how justice may be sought for certain groups of people, certain groups. So as I told you, I'm a gyno-oncologist. Please, next slide. Yes. So gyno-oncologists, we are top of the food chain. And the big issue that we deal with is managing complications from other gynecologists, whether from unsafe abortion, whether it is cancer care and stuff like that. So we deal with the more difficult surgeries at that. That's how I come into that. But I'm also, I told the immediate past president. I'm also a member of the NASMEC. NASMEC is the National Safe Motherhood Expert Committees. It is during, I was thrown into the mix in COVID when I joined the committee in AOGU. And at that time, the government did not know what to do. The mothers were dying, but they could not reach them. So we were asked as AOGU to engage with the ministry, and that's how we come on, and later develop that Safe Motherhood Committee. This is not a government or a Ministry of Health body. It is a committee of experts, university professors, researchers, CSOs, and of course the obstetricians to give direction. Now this committee was tasked with, number one, to make sure that health center 4s are functionalized. And up to date, and as we speak now, I think about 83% of health centers, Center 4, are now functional and able to do cesarean section. As we speak today, a lot of blood banks have been built because of the advocacy that we had in those areas. As we speak today, we know almost every mother who dies in a health facility because of the work NASMEC does. And in this morning, we are having some audits from the mothers who have died today. In terms of reproductive justice, of course, there are issues. Doctors don't understand rights a lot, don't understand, but we understand health because we offer services. So rights, health, and justice are a continuum of things. And at some point you may be dealing with the rights of the woman, giving her a service, as well as advocating or ensuring that she receives the justice she needs. So rights, the legal people like SEHAD know, and other organizations. The reproductive health, we are the experts in those areas. Now the issue is now the justice, that whatever we do, has there been justice for an individual, but also the communities where these individuals come. So justice, I chose that definition, which is based on complete physical, mental, spiritual, added political there, political, and it's good we have politicians in this room, that affects health. So rights, what the woman can do. She can decide when to have and how to have. Now of key importance is that we should not forget women who are struggling with infertility, because they also want to have and when to have. And I'm aware Parliament is discussing something on reproductive technologies. Sexual health. Women should not be coerced into sex. They should not be exposed to STIs and their effects. Those may also affect the enjoyment of deciding when and how to actually have children. Then of course, women have to be able to reproduce safely in case they choose to have a pregnancy. And the services where we normally fall are normally in maternity, and of course abortion services. People don't want to mention abortion. I know at NASMEC we have several committees. We have PPH, which is for hemorrhage. We have one on hypertensive disorder, that's why they are going down. But we don't have one on abortion, because we have to keep mum about that topic. So we speak mainly about post-abortion. Of key note are the tragedies in the reproductive health. One of them is the adolescents. We keep mentioning them, but the more things change, the more things remain the same in that category of people. Then mothers dying, especially from unsafe abortion. We are able to speak freely about bleeding, about infections, but not about abortion. Infertility is now a big problem in the country, despite Uganda having a very high fertility rate. And of course, the women in this room, whether you're 20, that phase is coming, menopause. So if you are 40 and above, you've begun that phase of menopause. Don't forget about it. We can move on, please. So, at the moment, what is happening with the females in the country? If you look at the National Housing Census 2024, we have 23 million women, females. Let me call them females. Of those, 5.6 are between the age of 10 and 19. They are adolescents. A very big number. That's the whole country of young people. Then we have 2.2 million females between the ages of 15 and 19. I am focusing there because it's important to me and to the people here to look at that group. Then, of course, there are 4 million women. When the government took power in 1986, there were less than 400,000 women above the age of 40. 1991 census, there were only 0.7, 700,000 women above the age of 40. Now there are 4 million. It means something has gone right, but also creating a new problem. Okay, something has gone right, a new problem is happening because of these numbers increasing. Now, of course, in the UDHS 2022, we are very fertile, still very fertile, I think among the highest in the world, at 5.2 births per woman. And of course, because we are ganging up teenagers with other women, we have a very high teenage pregnancy rate. I am not sure if we used to measure teenage pregnancy rates before 1969 census, because I think it was acceptable for teenagers to get married. So then why count their pregnancies? It is a normal thing. Yeah, so think about that. So in terms of tragedies, I think the first one is the way we name and classify the girls between 15 and 19. We classify them as women of reproductive age. So if I am a man, I will treat her like a woman because she's of reproductive age. If I treat her like a woman and you arrest me and I go before a judge, it is us who said they are women of reproductive age. So is there a need to change the nomenclature and the classification for that group of girls, or children actually? Otherwise, we shall treat them like women and the problem continues because they are women of reproductive age. And all our documents, whether WHO, FIGO, our I think our UDHS puts them as women. So are they women or they are children? We can move on. So then after classifying them as women, then we start shouting that they are pregnant, from the CSOs to the doctors to the judiciary, but we said they are women. So why are we now crying? So there must be a need to sort out that issue for that patient. So as I told you, there are 2.2 according to the census in that age group. And if you take literally statistics of 24% of them are either pregnant or have had their first child, it means you have 500,000 girls who are either pregnant or have had their first child. So it means every day 1,500 people are walking into Nachivubo State on Ambole. It will fill up several times because of that problem. So there is no policy. There is no policy, I'm very sure, on contraception for these girls. We've called them women, we have made them pregnant, and we are denying them a chance to prevent the next pregnancy for whatever reason, but society has called them women. So most of these pregnancies, if you look at the studies nationally, locally now, there are lots of studies from universities to rural areas. Most of these pregnancies are unwanted, or they were coerced into sex, and of course a good number of them will seek to terminate pregnancy. The issue now is that they will seek the unsafe way. My belief also is, even in public facilities, the abortions are unsafe, even for the right medical reasons. They still remain unsafe. Unsafe means the right person, using the right method, not outdated methods, and in a clean environment. And if you visit many facilities, we don't meet the standards of safety for abortion. You can move on. So think about the policies and the justice around those areas. Then tragedy number 3, move on. Women still dying from unsafe abortion. Now, the strange thing in where I work, or where I've visited, because I'm on top of the food chain, I tend to see the worst cases. But also for some reason, women think that I do terminate pregnancies for social reasons, because I speak about them. Now, I'm seeing a big number of women between the ages of 35 to 44 who are coming in seeking abortion. They want to terminate the pregnancy. Not teenagers. Some of them have delivered 6 times, 5 times, but they also need the service for some reason. And therefore, we cannot ignore that age group as well. They are still in reproductive age and also require the services. Then 2, because of the fact that we don't speak about safe abortion, of course, their movement, safe abortion was defined as within the extent of the law. Now, the law in Uganda is very unclear. Even for us, the doctors, what are the legal terminations? Of course, we terminate pregnancies to save the mother's lives. But if somebody took me on, would I be secure? Now, that has affected the way we are trained. Many institutions have refused to train their students, both medical, nurses, including masters, people like me, specialists, on the proper ways to terminate a pregnancy, because they fear that if you train Musana very well, he will go and use what he has learned to terminate pregnancies out there, outside the legal regime. But normally I ask them, if you're training the army, do you choose who to train well and who to train poorly because you think he honorable will become a rebel? You must train the ones who are going to defend you well, then they can choose later and you deal with them. But train everybody the right way. And of course that training will impact even the women we are treating for what we call the medical emergencies. That training will impact. That said, you have a new guideline that speaks about post-abortion care. Now, 25% of the women who are dying in Uganda are below the age of 24. 25%. So out of every 100 women who die, 25 are below the age of 24. And the biggest killer is abortion. But we don't speak about it. Okay. Now, the Ministry of Health has taken, I think, very good steps to actually try and deal with the problems. If you look at this report, which is the harmonized facility assessment, looking at readiness of the facilities to tackle several problems, from NCDs to maternal health to child health, there is an issue there. Much as we don't have a policy on abortion, I found something very interesting in that section, in that table 91, about adolescents. Please go back. About adolescents. 48% of facilities nationally have some form of adolescent healthcare services. 64% give them contraceptives, some form. Now look at the end where there is abortion. About 6% of them are offering abortion services, which is also terrible. That's very low. Yet they're the ones having most of the abortion. So where are adolescents going for abortion services? Whether it's post-abortion care or whichever abortion, where are they going? We can move on. So, tragedy 4 is starvation amidst plenty. Our women are very fertile. You touch, baby. One sperm, 40 billion egg, 40 billion cells form a baby. But there is that category of women, even if they have conceived before, they're coming back complaining of inability to conceive. And Uganda has among the highest rates of infertility world over. Maybe that's why the law is coming. However, is the law just? Is the bill in its current form, is it just to meet the actual needs of the women? There are issues around surrogacy. And of course, I read somewhere that surrogacy will be free. And I'm like, who would give their uterus for free? For 9 months, suffer complications. So there are issues around the justness of that. 2, how do they access? Given that in our public service structure, the one for the doctors, we don't have fertility specialists at general referral levels, where the women tend to come from. I say women from Buhinga, Soroti and other places who are coming for fertility issues. So think about those issues of justice for people who have infertility. You can move on. Please we move on. Then, since I'm from the biomedical background, if you don't appear here, don't worry. I'm looking at it from my lens. We have an axis of gatekeepers. It's a very big axis. It doesn't matter whether you're the president, whether you're the chief justice, whether you... Once you find a doctor, you find a lawyer, and you find a religious person, a priest. I think we have some here. We can be good or bad for you because we are gatekeepers. Now, the doctors and the lawyers and the judges and the priests, what do we have in common? We're the only ones who will do penance. You know what penance is? You come to the priest, confess your sins, and the priest is required to hold your peace. You come to the doctor, you will confess, open up. You come to the lawyers, the judges, and other things, you'll also confess. So the responsibility in reproductive health lies with the gatekeepers, because sexuality and sexual conduct in Uganda has been, if you look at university girls, for example, there is evidence that 50% of the girls joining university have never had sex before. 50%, half. The number one reason for not having sex is because of their religious beliefs. But by the time they leave university, those 50%, 70% of them have begun action. But they still go to church, they still go to the mosque, they still go. So what has gone wrong before they come and when they're in the system? What has gone wrong? So those 3 gatekeepers, I think, are people that we need to focus on in trying to build solidarity around these issues. We can move on. So let us triangulate those 3 gatekeepers. I know we are in this house represented at some levels. So seek allies in those in that tripartite of people, so that since they, like for example, Minister of Health, all the 3 ministers are female. The accounting officer is female. Clinical services, those are the gatekeepers. The directors are males, but they're also gatekeepers. Let us think about that. Okay, we can move on. So, religion, I spoke about it. People in Uganda, it's not going to change very soon. They will still say, I've remained chaste because of my beliefs. But how do we merge agendas? I know people in the CSO world don't like to hear about the thing called abstinence. But I think if you ally with the religious on abstinence, it means, because I know now I've heard there is primary and there is secondary. Primary, I am a virgin. Secondary, I'm a secondary virgin. Now, the reason for abstinence is not to prevent pregnancy. It is never to prevent pregnancy. It is to prevent the sex. Now, as reproductive health movements, reproductive justice movements, why are you against abstinence? Instead of asking the people who are promoting abstinence. In the time somebody is abstaining, whether primary or secondary, what is the information you're feeding them about sexuality? So that when they begin having sex, they are safe from STIs, HIV, coercion, discrimination, and they will not get an unwanted pregnancy. So that you can merge agendas in those areas, and I think that's very, very important. We can move on. The medical practitioners, including myself, we are gatekeepers. We are gatekeepers, especially the doctors, because you're the ones who are in the positions of responsibility and accountability. So how do we engage those people and hold them accountable? As the president AOG, I have my colleague here who's sitting on the committee, we began an accountability tour in the country to ensure that all obstetricians in positions of power began to report all deaths. Now we ended up with NASMIC, where we can tell where the mother died, the doctor who treated her, and the problem which actually happened. So accountability of those gatekeepers. I'm aware that the ministry is trying to design efforts around the councils to see if they can actually improve accountability by the gatekeepers within the sector. Then of course, recently, January somewhere, I'm aware that the Justice Odochi issued a ruling against Dr. Jane Ruth, the Minister of Health and Attorney General. I think it was done by HIAPI, where she was ordered to issue instruments to regulate the private sector. That included asking the medical council, the one where we belong, to actually regulate the private sector, regulate prices, and also deal with issues of detention. So, does litigation play a role? Does litigation, please, if you sue me, don't ask for money. Just say public interest. The rest will follow. So you can move on, please. So, as people in this room, the CSOs, people from medical fraternity, the priests, can we consider, let's move on, please. Can we consider using litigation to actually make those who are accountable do their work? So I think I would like to end there. There are various avenues: litigation, partnering with the councils. Our councils are not very strong, they are weak, but the laws are there. But the laws have never been actualized. But I hear they want to revise them. So you revise what has never worked. But the laws are actually very clear on some of these issues. Malpractice litigation. If it is against me, please don't put money at the end of it. Just say malpractice for the public good. And then in medicine now, medical practice, we have 3 types of professionals. We have the doctors, 4, the pharmacists, the nurses and midwives, and the allied professionals. One of the biggest things happening now is called scope of practice creeping. Somebody pretending to be what they are not. A pharmacist opening a consultation room in the pharmacy, and a woman will come, get services, and get problems. A gynecologist like me doing surgery for the intestine, but I have a surgeon next door who is proper. So are the women getting the right services? And who is seeking justice for them when, as professionals, we abuse so many things? So can we consider that as well? I'd like to end there, and hopefully some of those issues can guide you move forward. Thank you.
Another round of applause for Dr. Musana. I like the calmness he uses to put forward these critical and sensitive issues. But the emphasis he puts speaks volumes, and I'm sure all of us here we've had. He has mentioned for us clearly the 4 tragedies we have around adolescent and teenage health, which leads us to teenage pregnancies, the issue of maternal morbidity and mortality. We know the statistics. infertility. He highlighted it very clearly, but he mentioned that we are among the most fertile nations on this country, which also leads us to that unmet need of contraception in this country. And a very other issue about menopause, premenopause, which we also need to think about critically, because we cannot shy away from it, especially the women who are in the house today. Very importantly, mention the axis of the gatekeepers, and I want to assure you that most of those gatekeepers are here today, and they are going to tell us more about what they are gatekeeping for us to be able to address these issues. So we have the medical doctors here, the lawyers are full in this house. We have Reverend Nathan. I think you represent the whole fraternity of the priests and other religious leaders. So we'll dive deep into those discussions today, and we see how we move from here with a couple of solutions. So ladies and gentlemen, allow me welcome our distinguished panelists who are going now to digest further what Dr. Musana has mentioned, and perhaps share with us some of their insights, the experiences, and put forward some of the solutions on how we can collaboratively work together in a reproductive justice movement to address these concerns. I want to invite our first panelist for today, Williams. I usually call her Bookie because her name is quite tricky to mention. And she hails all the way from West Africa. So you know that if I say her name is tricky to mention, she one time said, don't struggle, just call me Bookie. She will tell us the full name and you attest to what I'm saying for you today. So Bookie works with Akina Mama, and she's the SRHR lead. You're most welcome to our panel today, and we look forward to hearing your insights. We also have Dr. Deogratius Migade from the Ministry of Health. He's a senior medical officer under reproductive and child health. Our next panelist will be Reverend Nathan Mugalu, who is the Executive Director for Family Salvation. Please welcome him to the panel. And lastly, we'll have Honorable Rita Atkwasa, who is the Member of Parliament, Mbarara City. We welcome you to the discussions. So, Dr. Musana, the gatekeepers you mentioned for us are here, and we are gladly going to hear from them on how do we diagnose the issues at hand. So without wasting any further minute, and like I said, we are live on NTV, and we'll be getting more insights in this discussion. I want to begin with our first panelist, Bookie, and please don't forget to mention the full name for the people to know the actual full name. So Bookie will be telling us what are some of those existing barriers around reproductive justice, and what should we be paying attention to in order to achieve reproductive justice in Uganda. Please go ahead.
Thank you. It's not that difficult. Okay, good morning, everyone. My name is Ola Bukuola Williams, but you can call me Bookie. And so I think a lot of groundwork has already been done around what are the existing issues, and I think we all can figure out what these barriers are, but I think it's always worth mentioning them again. Especially in terms of, we've heard the medical issues, we've heard the statistics, we always hear the data, but the truth is I feel that when we hear those numbers, we don't think of them as individuals. We don't think of them as a family member. We don't think of it as somebody we could walk past in the street. We don't think of it as somebody close to us who've had to go through this, right? Who's had to seek an abortion, who did not have access to it, or who didn't have enough money to pay for it, or who felt stigmatized, right? Or feel like they're going to, in many times we think, going to hell if we have an abortion. and that stigma that comes from not talking about it, right? Or pretending we don't know anyone who's gone through an abortion. And those are very real things that happen. But at the end of the day, I think we are also in a difficult position where we don't think of access to abortion as access to healthcare. Because at the end of the day, that is what it is. It is a medical procedure. We have put a lot of issues around it, socially, culturally, and in terms of religion. But the truth of the matter, at the end of the day, it is a medical procedure. And I think that's one of the biggest barriers that we face, is that women need access to this medical procedure for various reasons that we all know. In terms of just for health reasons, so that they don't die, or even not just dying or having other complications in terms of that. For women who maybe didn't get a choice, as was mentioned earlier, to be able to practice family planning. They don't get to make choices over their own bodies. Those decisions are made by other people in their lives, whether the person they're married to, whether other family members. And that lack of choice means they often have to make that decision, right? For economic reasons. And that's actually something that's very real for a lot of African women, right? When you have 5 children that you have to feed, we are currently in a cost of living crisis. We all know inflation. Every time you go to the market, the prices have increased. That burden, who bears it? And until we can have that conversation, and that's why reproductive justice is important, because there was, he was saying that we don't, maybe doctors don't understand rights. But often when we talk about rights, we pay lip service to it, right? That you have the right to health, you have the right to education, you have the right to shelter. But the truth of the matter is that if you have that right, who's responsible for it? Who has the obligation to ensure you have that right? And how many people have enough decent work to be able to access that right, or to have that right? Right? We have a very young population. How many of them have access to decent work? That they have enough work that they will be able to pay for their rent, that they'll be able to feed themselves, that they'll be able to enjoy even being young. Right? How many of them have access to that? In reality. And so if we're not creating an environment where people can have access to decent work, where they have economic power to be able to make that decision, where we also respect them enough to give them the information to make decisions. When you talk to a lot of young people, I remember when I was, doing peer education in safe spaces, the most popular topic was always the issue of bodies. Because many young people don't have access to information about their bodies or about their reproductive system. We just assume that they're going to learn it. How many people are parents in here? How many people have kids in here? Great. How many of you have sat down and spoken to your children about their bodies?
They speak to us.
You see, why are you waiting for them to speak to you? They're the child. You're the one who's raising them. How many of you have had that conversation with them, that this is your body part, this is what it does, this is what it looks like? But if you don't do it, who is? In my country, there's a proverb that if you don't teach them at home, they'll hear it outside. Right? So if you're not giving them that social power, and if you don't help young people to understand that the first power that they have is over their bodies, then what kind of society are we building? And so when we are talking about barriers, there's also those social barriers, which then makes it easy for us to use shame. Shame of not knowing, shame of making a decision, shame of even not making a decision, right? Or that decision being forced on them. And we still make them feel shame for the fact that something was forced on them. So until we start to unpack these things, we won't have rights, neither would we have justice. And we will continue to see young women die because of that. So it's quite important for us to think very, very deeply. And Amilcar Cabral says we must claim no easy victories. So until we get to a point where often young women, in all of their diversities, die from abortion, we can't claim any victories at all, right? And I think it's also important to remember that the kind of young women who die from unsafe abortion, or who are hurt from unsafe abortion, are often young women who are already facing multiple forms of discrimination. They're poor, they're living in a rural area, sometimes they're forced to be the heads of their households. Those are all of the realities that they face, right? And it's quite important to remember that, or they don't have, high levels of education, or they're women who are already facing violence in their homes. And based on research and most of the stories that they know, a lot of women face a lot of violence even when they're pregnant. In pregnancies, when they even face some of the most violence that they face in their homes because of pregnancy. So until we create